This is a talk that basically every week or so over the past 4 months I could have done a complete overhaul of what the talk will look like. But I think as of this morning, this is still fairly current, but you can tell me if current events have superseded in the last 3 hours. So what I'd like to do is kind of really a two-part talk. The first is to go through some of the research findings from work by me and various collaborators at Harvard and elsewhere, looking at what we know about Medicaid under the Affordable Care Act. Part of that is really piecing out the elements of the ACA and how they've affected coverage and what parts of the law have done what. And then looking at Medicaid impacts from the patient's perspective on a variety of different measures, looking here at primary and preventive care, ED use, chronic disease management, prescription drugs, surgical conditions. And then also turning away from the individual patient level experience and thinking about state budget impacts. A couple of those I'll do a little bit of a deeper dive on 1 or 2 papers, and I'll give you some high-level findings from a couple of others. But I think some of the most interesting conversation to be had today, and I hope you'll engage with me so it won't be just me talking, is thinking about what's next and what do we know about the current reform proposals that are out there, what might be their potential impacts, and what are their prospects for passage. So to start off, very simple graph that in some form or another all of you know, which is the Affordable Care Act has led to historic drops in the uninsured rate, starting primarily at the beginning of 2014. And this is true no matter what data source you look at. And there's been a whole lot of studies. I mean, this is just a very rapidly growing field of research. There's been no question about this drop in the uninsured rate. Various studies have tried to figure out how much this might be the economy, and a nice paper by folks at Urban Institute basically concluded almost all of this is the ACA, and very little of this is economic recovery. And there have been a whole bunch of differences analyses comparing states that expanded Medicaid to states that didn't and showing big impacts for low-income adults. And I'm going to show you some of our work on that too. But for the paper I'm going to spend the first 15 minutes or so talking about was to really understand what parts of the law were doing what. This historic drop in the uninsured rate, how much of this can we attribute to different pieces of the ACA, which really is a multi-pronged approach to coverage expansion, and it has important implications for considering partial repeal or alternative proposals like the American Health Care Act that was recently being debated in Congress. So in a paper that we have that's coming out shortly in the Journal of Health Economics, but it's already online if you want a working paper version, John Gruber, Molly Freen, and I really tried to piece out the main policies in the ACA that could have affected coverage. So first, of course, is Medicaid expansion. I'm going to break that down in a little bit more detail because it's not just expansion of eligibility, but Medicaid premium subsidies to help people go buy marketplace health insurance, and then the individual mandate. So the basic approach we do here is to take a really large national survey database that has a lot of rich detail and geographic information. It's the American Community Survey. And we're basically going to do a couple of comparisons. So it's a triple difference model because we're going to look before and after the ACA. We're going to look based on different income groups, not just high and low income, but the gradation of income, because the ACA has a whole lot of features that are targeted to income, not only Medicaid eligibility, but how much tax credits you get to buy insurance in the marketplace. And are you subject to a mandate penalty? How big a penalty? And then we're also going to use geography. Probably many of you are familiar by now with the notion that you can look at these expansion versus non-expansion states, but we do more than that. We're also going to look county by county within states, or more precisely these rating areas, which are the areas that the ACA sets up the insurance options for people who are going on the marketplaces. And some of the rating areas have a lot of insurers and have low prices. Some of them have high prices. And we also know that there are a lot of differences even within a given state as to what share of a county or an area in the state might be uninsured. So we use all that variation and essentially want to kind of figure out the impacts of Medicaid, premium subsidies, and the mandate. So we're going to use microdata from the American Community Survey. It's the country's biggest household survey. And we developed these kind of household measures. We put everybody into these health insurance units, which are basically family units for the purposes of coverage. And we're going to focus on people below 65, but including children. And the good thing about the ACS is it's huge. So you get 2 million observations per year, and you can really drill down within states to look at where people live. And there are these areas within the survey that are called these public use microdata areas. They're about 100,000 people or so in population. And so in some states, that's like 10 counties put together if you're out in, say, the upper Midwest Great Plains states. Meanwhile, in Chicago, you might have a dozen within the greater Chicago area that each one is an area of the city that has a large population. And so using that, we can really do some rich analysis looking at what kinds of premiums people face and the number of people who might gain coverage. So we code up Medicaid eligibility. I'm not going to go into a lot of detail on these slides, but if there are questions, feel free to interrupt me if things are not seeming to make sense. And eligibility in Medicaid, as you all know, is a function of age, income, do you have a disability or not, and then family structure. Are you a parent of a dependent child? Right, that's the way you get Medicaid in pre-ACA if you don't have a disability. Are you a child yourself? Then your Medicaid eligibility. We don't know if you're pregnant. We can't tell that in the survey, so that is one thing we can't do. And then we divide Medicaid eligibility into three groups because they have really different implications for not only the ACA, but then thinking about repealing parts of the ACA. So they're the folks who are already eligible, so pre-ACA eligibility as of 2010. And then there's a handful of states that started to expand before 2014. These states took the early expansion option under the Affordable Care Act, and they started to cover some, but not all, of the people who would become eligible in 2014 under the full expansion. And then we have the states that opted into the full ACA expansion starting in 2014, with a couple more states coming on board in 2015. And the reason this matters is because there are different financial implications, how much money states get for these people. There are different issues in terms of kind of the burden of disease and public health implications. And also, when you start pulling back pieces of the law, whose enrollment is likely to be most affected. So this is just to give you a sense that there's a lot of variation, and it's not just expansion versus non-expansion, though that is a big piece of it. So first, you can look at the non-expansion states that are in red. And what this tells you is that as you go up the income distribution, not surprisingly, there's more Medicaid eligibility in the lower income range, and that as you get much past 100% of poverty, most of these expansion states cover very few people. Small numbers of parents in a handful of states where they'll cover kind of parents around the federal poverty level. Even before the ACA, the states that went on to expand were more generous at baseline. Illinois, Massachusetts, New York, California, they all were more generous with Medicaid even before the ACA came along. And that shows up in the fact that these yellow triangles already are higher up on the income distribution. And then the ACA, of course, though, makes a huge difference. Even in states that were pretty generous, like Illinois and New York and Massachusetts, this line now goes up to basically 100%. Now, of course, there is one group that's not eligible, and that's based on immigration status. We don't have those exact, we don't have the immigration status directly coded here. When we make some adjustments for it, it doesn't really change our overall results. But the big picture here is now if you're a low-income adult, the ACA has made you eligible. For premiums, it's a little more complicated because we're dealing with these marketplace premiums that there are in some places dozens of plans that you can choose from. And it maps onto all of these different rating areas across the country, dozens in some states of different areas where different plans get to set prices differently. And what we do is, in each of these rating areas, we identify the second lowest cost silver plan, and that's the plan that gets pegged to the premium tax credits. Right? The ACA essentially says, for whatever plans are available to you in your area, let's find the second lowest cost silver plan, and you only have to pay X% of your income. The rest of that will get taken up by the federal government, and we'll pay for the rest of the premium. And it's also the level of the marketplace plans that was most commonly purchased. There are these bronze, silver, gold, and platinum, but the majority of plans that people purchased were on the silver level. It is priced based on your age, and so we include that here. And then we figure out how much subsidy you're eligible for based on your income and your family size. And so now you could do this and come up with a dollar value, like how much would it cost you to buy coverage. And we test that in our paper. But we actually think, it turns out that in the results, the more useful measure is actually what % subsidy you get, where someone who might get up to 100% if they were basically free coverage, 0% if they were too rich to get any sort of help, and for many people in the kind of middle income range, they're getting a partial subsidy. And the reason this % subsidy seems to work better than the dollar value is because it not only captures how much you're having to chip in, but the quality of what you're getting. Like, what would you be spending otherwise? And so in the data, that we kind of let the data tell us the story that this measure seems to do a better job explaining what people do. So what does this measure look like across states and across income groups? Non-expansion states have a little bit extra a portion of the income distribution that can get tax credits. If you're in a state that didn't expand and you have an income between 100 and 133% of poverty, you can get a tax credit. If you're in a Medicaid expansion state, you can't because you have to be in Medicaid. That's just, you don't get to pick between the two. And then the subsidy kind of slides down. It's not quite linear, but it moves down. It pegs your, your share to how much you're earning. And then above 400%, you pay the full price. So we get a fair bit of variation to look at in terms of how people are responding to these premium subsidies. And then finally, there's the mandate. So it turns out that about 40% of households in the US are likely exempt from the mandate based on our analysis. 20% of them are because their incomes are too low. Now, a lot of people don't really understand the mandate details well, but it turns out, so if you are below the federal income filing threshold, you don't get charged a tax penalty for being uninsured. Meanwhile, if you were in a state where you would have gotten Medicaid if the state had expanded, but they didn't, right after that Supreme Court ruling, the Obama administration said you'd be exempt as well. So you wouldn't be penalized because your state didn't expand. The ACA takes several different approaches towards coverage for Native Americans, and one of which is that the mandate does not apply. And finally, there's this affordability exemption, which basically looks at how much does coverage cost to you in your area. And so in some parts of the country that are a little more expensive, if you don't get a tax credit, it might be pretty onerous to have to buy marketplace coverage, and then again, you'd be exempted. So this gives us some variation by income, by geography, and it's going to let us see, do people facing bigger mandates, holding all else equal, seem to sign up at higher rates? And then if you're subject to the mandate, here are the dollar amounts. And it, again, goes up with income, and it also goes up pretty significantly from year 1 to year 2. And so that's another way we can kind of see what the mandate might be doing. So there's just a graph showing you that. Don't worry about this page. I just show you this because I want someone in the audience who's like really focused on econometrics to think that I can do a regression. That's it. The most important things are that we're going to separately identify the policy effect for 2014 versus 2015, both compared to pre-ACA. And the reason to do that is because most expansions in coverage gradually ramp up over time, and we want to kind of see that in real time in our policy measures. And we're going to adjust for a couple variables that are worth noting, particularly the area unemployment rate, so we can try to pull out maybe to what extent the economic recovery is driving our results. All right, but that was already too much time for that slide on screen. OK, so what do we find? First off, just in terms of impact on any coverage, being uninsured, these are all percentage point changes. And they're kind of hard to interpret, and I'm going to show you in the next slide what they actually mean. The main thing to see here is that all of the effects get much bigger in 2015. So there is this ramp up. The same amount of subsidy in 2014 has only about 60% the effect that it did the next year. So there is this kind of gradual increasing going on. It looks like in kind of administrative data that we have hit the flat part of the curve under the ACA by 2016, 2017. There isn't a big surge up in enrollment, but there certainly is from the first to the second year. And a lot of the papers being published now are still mostly focusing on 2014 data, depending on the data sources. So that's just something to keep in the back of your mind. A new study may not always have new data. And so people are writing papers, understandably, with data that weren't originally available, but sometimes might be underselling the long-term effects of the law. All right, but this is probably the more relevant piece. What do these changes mean? Like if we try to compartmentalize and attribute the ACA coverage effects. What we figure out is that if you take the average subsidy in our 2015 coefficient, that the premium subsidies in the marketplace explain about 40% of the increased insurance coverage in 2015. So it's pretty big. But it does tell you then that the majority is actually something else, in this case Medicaid. The Medicaid effect has 3 pieces. And somewhat surprisingly, the biggest single piece is those who are already eligible. So I imagine someone in the audience has heard what people have called this. What do you call the previously eligible folks enroll? Anyone? Somebody heard the phrase the woodwork effect or the welcome mat effect? So the idea here is that there are actually a whole bunch of people in the US who were already eligible for Medicaid before 2014 but hadn't signed up for coverage. Why might someone not sign up for coverage? It's free. There's no premium in Medicaid. So why wouldn't you have signed up? I'm going to call on you, Cal, if no one else says anything. So, yeah. You don't know how. You don't know where to go. You may not know that there is even such a thing, right? You may not know that you're eligible, period. Great. Those are important things that have been shown in previous research. Other factors?
Before and even now, it's still very complex procedure. You have to have a lot of documentation.
Yeah. Yeah, absolutely. Right. I think so. If you get the Medicaid application from your state, I compare. It's fairly similar to filing your state tax return. So it's not unbelievably cumbersome, impossible to do, but it also is not checking a box, right? It's not straightforward. You imagine that some of the people who are eligible don't speak English or don't read in English all that well. Numeracy and ability to kind of fill out income-based information may be challenging, especially since many people in this group actually never have had to fill out a tax return because their incomes are too low. So there's the challenge of kind of completing the process. And then one more wrinkle is you may have done that once, but you didn't do it again. Right? Medicaid eligibility isn't indefinite. It's at most you get 12 months of coverage, and then you go through a redetermination to show that you're still eligible. And if you don't go through that, if you can't complete the paperwork, or you moved and you didn't get the packet from the state, or you didn't know you had to renew the coverage, this is the stuff I see all the time in my clinic, that patients of mine come in, and it turns out that they're ready for their visit, and their insurance has expired. And they are surprised to hear that they had to renew their Medicaid. So these are all factors that lead there to be several million people, by some estimates as many as 5 or 10 million people, who are eligible for the Medicaid before the ACA but hadn't enrolled. And so we find that there's a big increase in enrollment among that group. And there are a couple reasons for that. The Affordable Care Act tried to streamline this application process. They made the application shorter and more streamlined, and also tried to make it so that even if you didn't know you were Medicaid eligible, you'd get to the right place. If you went and tried to sign up for a marketplace plan, but it turns out your income was low, that was supposed to get automatically forwarded over to the Medicaid agency to help you enroll. They also got rid of some of the requirements that were keeping some people from enrolling, in particular asset testing, right? So it's not just that you have to have a low income. In many states, for certain groups of people, you had to show that you didn't have a lot in assets. For instance, in some states, you had to show the valuation of any car that was in your possession. That's not a straightforward thing to do. And so a lot of the people who might have been put off by these requirements actually didn't have, it's not that they had thousands of dollars in the bank, they just didn't get over the administrative hurdle of applying and getting through that asset testing. So the ACA got rid of asset testing for kind of generic Medicaid, not for the pre-ACA long-term care benefits. Those groups still often have to go through an asset test. And then there was just a lot of PR about this, right? I mean, I don't know that any of us have been in an environment where there was so much news coverage about health insurance, Medicaid, health care, than in the past several years related to the implementation of the ACA. So people were motivated and knew more about the coverage options. And that shows up here with this big increase in enrollment for previously eligible. Meanwhile, the states that expanded early, not surprisingly, you make new people eligible, they sign up, and we see that in both at the bottom too. But the fact is that so many more people were already Medicaid eligible that woodwork effect turns out to be pretty big. And meanwhile, what's going on with the mandate? Essentially nothing. So now I should be really clear about what that means. We're looking at whether you face a high, medium, low, or zero mandate. And what we find is that there's no evidence that that difference drove people to sign up. Now, could it be that the existence of a mandate, that there's something in the air and people know they need to enroll, that might have motivated people? Yes, it could be. But it didn't matter whether you actually were subject to it and how much you were subject to. So one interpretation here is the mandate didn't matter. Another interpretation is the mandate matters, but in a very general sort of sense, and it actually doesn't seem to hinge on whether you're going to pay it. People just don't understand the features of the law well enough for their specific mandate penalty to drive their behavior, which suggests that tweaking the mandate and making it 30% bigger probably wouldn't do very much. But eliminating it entirely might be. We can't really comment if people are signing up because they have a general awareness of this penalty. All right, this slide got a bit misformatted, but the point here is simply that the Medicaid expansion did not actually have a significant offsetting reduction in private coverage. This is something called crowd out. People talk about public insurance might make some people move away from private coverage. We don't really see any evidence of that, and if anything, we see this kind of probably hard to explain phenomenon. There's a little bit of an increase in private coverage when states expanded, but I don't know if that's real. But these are all pretty modest-sized effects. Yeah?
So I'm curious, what's Gruber's thought about this now? I mean, he used to say, the mandate is really the key to expanding coverage, other than through the private insurance markets. In light of these results, what's his take?
Yeah. Well, I can't speak for John. We could Skype him in. No, I mean, I think the conclusions we make in the paper are what I just said, which is that we can't really conclude whether the mandate has kind of a global effect on encouraging people to sign up. There's no counterfactual for that, right? I mean, there's no place where the mandate wasn't at least talked about and in the air. But on the other hand, there is pretty good evidence here that the dollar value has modest impact, if anything, on what people's enrollment decision was. Being subject to a $500 penalty instead of a $200 penalty, or meeting the affordability exemption, was so in the weeds for people that it doesn't seem to have affected their behavior. So from this, I would say that among the various issues on the table in the ACA repeal debate, I think the marketplace subsidies and the Medicaid eligibility, supported by kind of ongoing federal funding, are a whole lot more consequential than whether the mandate gets weakened or potentially even eliminated. And the AHA didn't eliminate the mandate; it shifted it to a different format, right, which is a one-time penalty on coverage if you had a gap. I think the CBO got it right in the aggregate that the number of people who might lose coverage under the ACA. I do think I would probably come up with a different decomposition of it. The Congressional Budget Office attributed a lot of the losses of coverage under the Republican proposal to the elimination of the mandate. I don't see a lot of evidence to support that. But if it's not the mandate, it's the affordability features. If you don't give people money to buy the coverage or you don't make Medicaid available, that's obviously going to have a huge impact, and that's what we see here. Yeah. Harold.
There are some of the welfare reform policy analyses 20 years ago had some similarities to this, where there were a bunch of prior experiments, changing the AFDC, where they found that sort of tweaking the details of the program didn't matter that much at the margin, but then when you really do something fundamentally different, you can imagine the mandate matters because people have this general sense, I have to have health insurance.
Right.
And if I don't, I'm going to get fined. I actually don't know. It could be that if you tweak that fine up a couple $100 or whatever, people don't even know that that incentive exists.
Yeah.
But it changes the expectations and the norms and all that kind of stuff.
I think that's probably right. And from 2015 to 2016, the mandate penalty goes up significantly, right? It for some families nearly doubles. And we know from the marketplace enrollment that didn't boost enrollment dramatically in 2016 compared to 2015. So if you thought that it was kind of the dollar value and that you just needed to make this a stiffer penalty, the lack of an improvement in coverage in the marketplace from 2015 to 2016 would be a pretty hard piece of data to reconcile. But I think absolutely the case that if people are generally thinking I have to sign up, I should sign up, scrapping it entirely might have some harm. So what are the implications? I kind of hit on most of these as we went. I guess one point to add here is that woodwork effect or the welcome mat effect of additional people who are already eligible signing up, a lot of them are kids. So this is a group that is broadly have high rates of eligibility for Medicaid because Medicaid and CHIP are really the bulwark of children's coverage in this country. And many of the children were not enrolled even though they were eligible. One other factor that kind of drives this impact for children that's unique to kids, right, there's the streamlined application, there's a greater awareness, all that sort of thing. But covering parents actually increases the likelihood you cover kids, right? A lot of the parents in these states were not eligible. And it turns out that when you give parents not only the incentive to sign their kids up, but themselves up for coverage, that it tends to increase overall enrollment. And this is true in data. This is actually one of my dissertation paper. One of my dissertation articles was looking at how families make the coverage decisions together, and that when you cover parents and kids in the same program, you boost their enrollment and their retention in the program, and that seems to be happening here. Okay, so this is a fairly wonky paper, but it turns out that one fear when you write a paper like this is that no one pays any attention at all, and the other fear is that people do pay attention and use them in a way that you really wish they wouldn't. So this is when our working paper came out. This was right after the election. ACA repeal debate starts heating up. And I learned two things very quickly. One is, which is if you write a paper with John Gruber, it's a Gruber study. And the other is that no good deed goes unpunished. If you explain how coverage happened under the ACA, that someone's going to argue that the ACA didn't actually boost coverage. So this was kind of the argument that got circulated and ultimately worked its way into a position paper out of the Senate GOP on their approach to ACA repeal, which was basically, well, most of the ACA was Medicaid, and according to this paper, most of Medicaid was woodwork. So if you repeal the ACA, you actually don't make anyone uninsured, which was basically rounding 40% to 0 and then 45% to 0. But that said, this was their argument. It also takes I think the really dubious position that this was all kind of a happy coincidence, that suddenly there was this big enrollment among previously eligible people. And for all the reasons I told you, that's probably not the case. The ACA tried to do this, right? It got rid of asset testing. It made the application process easier. There was a lot of PR. It created these navigators to help people enroll. And so John and I wrote an op-ed trying to kind of counter this. And basically the argument we made was, this is flatly wrong. Most of the coverage gains that we're documenting here are probably direct effects of pieces of the ACA intended to boost enrollment. And if you were to scrap them and make the application process more onerous And we're already seeing evidence that this is the administration's plans. They're going to, they want to have states do redeterminations more often, stopping any funding for outreach to sign people up, et cetera, that you would probably see an attrition away from this enrollment. Yeah, Kevin.
Do you have any, I know it's way too early to know, but do you have any sense of whether or not the rapid AHCA caused panic people who were in the Medicaid
Yeah.
increased kind of the ripple effect?
So it's too early for anything rigorous on this, but there's, anecdotally, it could cut both ways, right? One is, oh my goodness, this law is going to go away. I need to get in there as quick as I can. Or, why sign up? It's going to be eliminated. I hear Obamacare is going away. And there is, when the administration took over, a couple of the early changes they made, they cut funding to advertise for signing people up from the ACA. I remember sitting at home in like early January watching TV, and these commercials for open enrollment were on TV, and I'm like, if Donald Trump watches as much TV as they say, this is not going to last. Ads saying you should sign up for healthcare.gov, and pretty quickly after they pulled the funding. And then there was also the notion that the law might go away. The ACA enrollment did dip down in the marketplaces in January. How much of that you can attribute to this? It's hard to say, but it's certainly kind of worth looking at. And over the course of this year, we're going to have a whole lot more features of policy that come out of the White House. Even if there's no legislation, the White House has a whole lot of ability to influence how long is the open enrollment period going to be. They've already proposed shortening it pretty considerably. How easy is it going to be for people to get information and support if they're having trouble with the website? Are they going to have to go through additional hoops to get coverage if outside of the open enrollment period? And then are we going to advertise for it? So all of those things, and having a president who's saying either we're going to stabilize the ACA or it's in a death spiral and we're going to let it collapse, those things might very well have big impacts on enrollment, and we need to wait and see how that plays out. Okay, so I kind of told you Medicaid is doing the majority of the work here in coverage expansion, about 60%. And then we want to know not just total coverage, but what's the effect on patients gaining this insurance? So the Supreme Court ruling in 2012 made the ACA expansion optional for states, the Medicaid expansion. And this was potentially terrible for public health and for health equity, but really good for research design, right? And of course, I would take the former over the latter, but there have been just a slew of studies that have this very nice, easy framework for evaluating the effect of expanding coverage. So now there's, I'm going to show you now studies, several different studies, and they have, different papers, slightly different treatment of, states that started early, states like Massachusetts. But for the most part, the basic framework is let's look at expansion states, let's look at non-expansion states, and let's follow the low-income adult population that's really the target of the ACA expansion. And some of this is going to be survey data, some of it's going to be from claims, registry, a lot of different data sources that you can look to try to understand what happens when you give people Medicaid. So first off, this is just some survey-based work, and there have been some national studies too using census and CDC data. What we did in this paper was we fielded our own survey, and we focused on 3 southern states that were taking different approaches. We looked at Arkansas and Kentucky, which expanded coverage, but differently. Kentucky did a traditional Medicaid expansion, mostly Medicaid managed care. Arkansas did the so-called private option, where they got a waiver approved by the federal government to take federal dollars that were supposed to go to Medicaid and instead buy low-income adults private insurance on the marketplace. Subsidized coverage, so they didn't actually pay any premiums, and they had their cost sharing, their copays reduced so that it wasn't too expensive for them. But they were in private insurance instead of Medicaid. And that was a compromise in the state that then Governor Beebe, who was a Democrat, negotiated with a Republican legislature, and they were able to get this approved. And then meanwhile, Texas didn't expand and generally was pretty hostile to all elements of the ACA, navigators, application assistance, outreach, et cetera. So first, these results pool together the 2 expansion states. So this puts Kentucky and Arkansas together and basically says, well, what happens to these low-income adults in these 2 states when they expand compared to the non-expansion state? And you see big increases in access to primary care, better affordability. People are less likely to put off needed care, less likely to skip medications. In my clinical work, I'm a primary care doctor, and probably the most important thing I do for my patients in terms of long-term health is put them on the medications that they need for chronic conditions. So this is kind of important. It's not just that they're getting prescriptions, but they're taking them and not having to skip doses. We see the financial protection effects that are so clear in some of the previous work, like the Oregon Health Insurance Experiment. People are just able to pay their bills. And we see an increase in checkups, which clinically isn't a great measure, but as a kind of a health services researcher is a reasonably good way of saying, are people thinking about prevention? People going in before they get sick. And then in terms of the patterns of healthcare use, they're getting more. They're getting better access. We see some interesting findings here that are a little bit different, actually, than some of the results for those of you who followed the Oregon insurance experiment. So we see that there's actually a reduction by 2015 in the likelihood of having gone to the emergency department in the past year for the low-income adults in these expansion states. And they're also less likely to say that the ED is their usual location of care. So if I can, let's see if I can manage to do this without messing things up. Yeah, there we go. So you see this 6 percentage point drop in going to ED. We see an increase in the number of office visits. And I already told you about the preventive visits, the checkups. And we see that they're less likely to say the ER is where they get their usual care. We also see an increase in glucose testing. So we're kind of seeing the shift towards the sorts of care we would want people to be getting, right? More prevention, more chronic disease management, less likely to rely on the ER. So one question that I think is important to ask at this point is, well, what does coverage do for emergency room use? Right? We have some really well-done studies in Oregon that were published in Science and New England Journal that show when folks there got picked for Medicaid by lottery, so they had a randomized trial, that they used about 30 to 40% more in the emergency department than folks who didn't get picked in this lottery. And there's really no reason to doubt that result. What I do, taking that finding along with ours, along with some of the other work that's come out on young adults who got coverage under the ACA in 2010 by staying on their parents' plans, some of these expansions do show a reduction in ER use, whereas others show this increase. And I think the point here is that it's actually not a straightforward relationship, right? There are these two competing factors. One is affordability. You made the ER more affordable for people by giving them insurance, so they're going to use more of it. That's kind of simple price response in economics. But on the other hand, you've now given them a better opportunity to access a substitute for ER use, which is going to outpatient settings. It really seems to matter about the context. So, what are the copay arrangements? What's the provider adequacy like? What patient population are you talking about, and what's the geography? How easily accessible are the outpatient settings? So I don't think there's a kind of a clear cut in every situation expanding coverage is going to dramatically increase ER use. I don't also think that the converse is true. I don't think the argument that we'll always keep people out of the ER by expanding coverage, the evidence is much more mixed than that. Yeah, Harold.
I must say, I do think progressives really jumped at this talking point about we're going to reduce ER use. And A, it was never evidence-based. B, it's not at all obvious that we want to be reducing ER use in the first place. Yep. And which visits will. And it just seems like one of these things where it came back to, it became politically damaging when when there was a result of increased ER use. Yeah. Because people used political talking points that were well-focused group but didn't really make any sense in terms of what we actually want to be doing. And it just seems like that was not the finest hour of a lot of health reform advocates to be pushing for this idea that universal coverage is going to reduce ER use. Yeah. I just don't even know that that's what I want to be doing. Yeah,
well, I think I have two responses to that. The first is that you're exactly right that we want to talk about which types of ER visits are you reducing. In some of the other analyses I mentioned, looking at the young adult provision, some work that I did with Coasley, Simon, and others, we show that the change is really concentrated in the kind of ER visits we'd like to get rid of. So they tend to be non-urgent conditions during normal business hours, when you would like people to be going to their primary care doctor. You're not going to get rid of someone with appendicitis going to the ER, and you're not going to get rid of somebody who at 2 a.m. is worried about their sick kid on a Saturday going to the ER. And you shouldn't. I mean, we don't want to dissuade that sort of use. But the kinds that maybe are a little bit less critical and could happen elsewhere. But the broader point, I think you're exactly right. It's not just about ER use. There was a sales job by some on the kind of pro-health reform effort that this was going to save society money by covering people. Even in our results here, there is no evidence that this is enough of an offset to save money. Covering people costs money. You have to pay for a lot of additional services, but it's an investment. And hopefully, with some of the other material I'm going to show you, it's an investment that is probably worth making, that people that have an improvement in well-being that we're using extra dollars to do. You don't generally expect that you're going to build a brand new highway, and a year later the highway is going to return $10 billion to your doorstep and say, look, I paid for it and more. It's an investment in having an infrastructure that is useful for other purposes. Healthcare, we're making an investment in people's health and in their well-being, and hopefully that investment's worth it, but we shouldn't actually expect to save money. That's different than what I'm going to talk about later, which is state budget versus federal budget impacts. But kind of in the global sense, I think, Harold, your point is right, that the notion that expanding coverage was going to somehow save us money in part by driving down ER use is not accurate. Even if it might reduce ER use in some settings, it's not going to pay for itself. But it might point to a more efficient use of healthcare that we can feel better about what we're investing in. And so then in terms of the downstream effects, is it just healthcare, or do people actually say that overall that things are getting better for the quality of their care? We see some evidence of that, and that they feel better. So one of Cal's dissertation papers looked at the same set of outcomes for young adults getting coverage under the dependent coverage aspect of the ACA, and found the same thing. People felt better when they had coverage, and we see that here, again, also very consistent with what they found in Oregon, where the people who won the lottery told you their health was getting better. But the other part of this study is really to compare the type of insurance people were getting. And so here, this is a busy graph, but essentially the blue bar tells you what was happening in Kentucky versus Texas, so traditional Medicaid expansion. The red bar tells you what was happening in Arkansas with the private insurance approach compared to Texas. And then the far right tells you whether Kentucky and Arkansas were any different from each other. And basically what you see is there are two big differences. People in Arkansas got private insurance and people in Kentucky got Medicaid. That was kind of by design. For all the other outcomes listed here, and actually another 15 that I didn't have room to put on this graph, we found pretty modest or non-significant differences. So basically, most of the benefits of coverage expansion were similar in the private option and in the Medicaid model. So there wasn't a dramatic difference in how the beneficiary was experiencing this. It makes a big difference if you expand coverage. It doesn't seem to matter nearly as much what type of coverage you're giving them. And if anything, Medicaid seems to stack up pretty well on a couple of these measures, a little bit better in terms of financial protection on the out-of-pocket spending. And the quality metric on the glucose check for diabetics is a little better. So if your prior was that getting private coverage was going to be much better than getting Medicaid, there's not much evidence here. On the other hand, if your prior was that public insurance is the best and we ought to go to single payer because it's so much better than private insurance, at least from the beneficiary's perspective, we don't see that. Now, the whole cost angle here is important to consider, and the private coverage almost certainly costs more. Yeah, well, go ahead.
Do you survey the states to see whether there are any things happening on the care delivery side that might provide some explanations for some of these differences, especially on the quality or setting of care?
Yeah, there were a couple things going on. I mean, obviously, there's so many changes constantly in healthcare. The only things that we could point to that were kind of going on systematically at the same time, Governor Beshear in Kentucky had, at the same time at pushing the expansion, had been advocating for kind of an increased focus on chronic disease care in Medicaid. So that may be part of what's going on with this diabetes glucose check. But I don't actually read too much into this. I mean, I would say that out of 30 outcomes, the fact that there are one or two differences is kind of almost to be expected statistically. And so, overall, I think it's hard to read our paper here and come away and say clearly one of these types of coverage was better than the other type.
We talked about this, but
Yeah.
in Kentucky, did they contract out with managed care plans?
Yeah, exactly. So Kentucky was, like most expansion states, a heavily Medicaid managed care approach. Arkansas was different in that they have no Medicaid managed care. And so they weren't, so when they did the private option, they were using commercial insurers that don't typically in their state do much with Medicaid, or have no, in their state don't do anything with Medicaid. There's the point that you and I were discussing this morning that you've written about, how different is the private option versus Medicaid managed care? It's a fair point. There are some policymakers who will say that it's a huge difference. Maybe that's a sales job and that the private option sells better as a conservative market-based approach. In some states, it's more different than others. In some states, the marketplace plans are basically identical to the Medicaid managed care plans, but in others, there's very little overlap. I agree with you. I think that kind of has to do with what do you do with these findings, and rather than, it's I think still the case that this is what Medicaid expansion looks like in traditional expansion states, what Kentucky was doing, and this is the private option. This is similar to what the other states that have been proposing it have been talking about using.
So most of them in Kentucky were Medicaid-only plans, not commercial plans also doing that?
There were some of each, and I don't actually know by percentage the enrollment. Yeah. Okay, so that's survey-based. We've done a lot of work with survey data in these three states, and yeah.
Actually, could I just follow up question
Sure.
on survey data? Risky behaviors.
Yeah.
Debts of despair.
Yes.
Angus Deaton. I haven't seen any evidence of changes in
Yeah.
risky behaviors from the expansion. Have you seen any?
Yeah, so there are a couple of papers out. I think Coasley Simon and her group had one in JPAM, and then there's a working paper out by Cordemanch and others looking at some of these, there doesn't seem to be a big shift in healthy behaviors, which, to be honest, I don't think there should have been much of an expectation that there would be. I mean,
Even with better self-reported health, less depression.
You know, I mean, part of this is statistical, right? So let's say coverage here, we see about a 25 percentage point drop. That's big. I mean, if you look at national data, we're talking 5, 6, 7 points. These two states were some of the most successful at expanding coverage. So with a 25-point drop in coverage, or in the uninsured rate, then you get about half that big an effect on some of the affordability measures. The annual out-of-pocket spending is a whole different, it's a log scale, so don't worry about that one. And then you start to get down to things like quality of care and health, self-reported health. I mean, this is like 4 percentage points out of 25. So, the majority of people aren't experiencing a dramatic change in the quality of their care. A subset are. And so when you start to drill down from coverage to access to health effects to health behavior, I mean, you might be there. It might be there, but you wouldn't see it in survey data of several thousand people. I'm not convinced that it could happen, but I'm not convinced based on prior evidence that we should expect to see big changes in people's health behaviors. I mean, the literature on the clinical side of this is things like smoking cessation, exercise patterns, healthy diet. Those are really hard to change. There are not a lot of great evidence-based practices. I mean, there are smoking cessation techniques that are effective, but they get quit rates up to like 30%. So, I mean, you take all that together, even if healthcare and health insurance is helping on those measures, it would be hard to find in some of these small surveys. And now with longer follow-up and bigger data sets, might it show up? It's worth looking at, but it won't surprise me if it takes a while to see, or whether some of those outcomes don't budge, and we have to find, I mean, healthcare is one small part of this broad equation of health, right? Yeah.
I think that a lot of the focus on does giving people insurance and improve their health utilization. I mean, that's like a second order issue compared to does it protect them from becoming bankrupt when you have coverage costs occur? Because that really is the fundamental purpose of insurance. So I wonder, so I'm glad to see these kind of decreases in financial variables.
Yeah.
Did you look at, were you able to, probably too small, were you able to talk about bankruptcy and that kind of stuff?
Yeah, no, not bankruptcy. We do have people basically telling you whether they had to skip making other kinds of payments and they couldn't afford other things they needed based on their medical bills, and whether they were putting off care. So we see clear evidence of affordability improving. It's a great question and a topic of a lot of philosophical and political debate, right? Which is, what do we expect health insurance to do? I assign to my students in one of their first assignments in my class every fall is to ask them, what do we expect health insurance to do, and why do we not spend a lot of time as a society talking about subsidizing people's life insurance, people's homeowner or renter's insurance, people's car insurance, right? There are low-income people who struggle with those bills too. If it's purely financial risk protection, we should be doing more of that too. If it's just a means of financial redistribution, we probably can do it more efficiently with cash. I agree it's a key function of health insurance, but if that were the only thing it did, I don't think we'd be having a debate about national health insurance. So I think, and just as a simple kind of matter of observation, if you look at the debate in DC, policymakers who are advocating for expanding coverage are saying it's going to do more than just help people pay their bills. These are the empirical questions that have to be evaluated to make those sorts of judgments. But it's, you're right that health insurance, insurance in general is about risk protection, but we seem to have different expectations for health care, which is why we spend so much more on health insurance than we do those other types of things. Yeah.
I wonder if a lot of the health effects that we will see from Medicaid expansion are going to come through the public health system with some of the severely vulnerable populations. So we were talking before, everyone that we do in our jail studies, everybody leaving the jail is now insured under Medicaid expansion. Most of them were uninsured before. A third of the people in Illinois living with HIV are ACA Medicaid expansion. And so you're not going to see that on this type of a study.
Right.
I'm absolutely convinced that if you put a third of the people living with HIV on insurance, it's going to improve their health.
Yeah.
And so it may be that, and figuring out how to leverage Medicaid with other public health tools may be, with these populations, really the frontier for a lot of the public health work that we need to do.
I think you're right, and I think that's where you need alternative data sources, either picking an at-risk population and focusing particularly there, or data sets that give you, more power. So for instance, I've written a couple papers looking at state Medicaid expansions in the early 2000s, states that basically did the ACA, or did the ACA Medicaid expansion early. They did coverage up to 100, 150% of poverty for all adults, whether or not you had a kid at home. And the original paper was in 2012, and we found these mortality changes from it. I went back later, based on some useful feedback from people who are more critical of the study, to look at what was going on with HIV, because this was concurrent with the rise of the antiretroviral medications, which reduced HIV mortality substantially. And what we found was there was a synergy. HIV mortality accounted for about 20% of our overall statewide Medicaid mortality effect. And the rates were declining much more rapidly in the expansion states. So it looked like it was not just that the meds were available, that they had come on the market and they were the new technology, but that was coinciding with an expansion of coverage that then gave people the ability to get that. So I think you're right that there are, if we're going to find health benefits, they're going to be not uniformly distributed across the population and across conditions. Okay, so moving away from survey data, and we're, let's see, about 10 till. Okay, so I'm going to try to give you some high-level results here without spending too much time on the methods. So I mentioned that the medication adherence finding, that people were less likely to skip meds. And as a clinician, what I want to know is, okay, well, which medications? Right? Not all medications are equal in terms of potential impacts on patients. So we used a large prescription drug claim database where we knew the drug class, we knew what type of coverage a person had, and we obviously knew when it was being purchased. And so we looked at the changes in expansion versus non-expansion states. And first what we see is you see a big increase in Medicaid prescriptions being filled starting in 2014. And we don't see much of an offset anywhere else. More interestingly, we can tell you what types of prescriptions people were filling. And so while across the board there's a 19% increase in the number of prescriptions, kind of monthly fills of medications, the biggest gains are for a few conditions that are kind of ongoing chronic medications, right? So diabetes and cardiovascular medications, this is like high blood pressure, cholesterol, heart disease, and then diabetes, whether it's oral medications or insulin. These are medications that people are supposed to basically be on for life. Right? This is where we're trying to really hit on some of the major causes of morbidity and mortality in the U.S. With heart disease, with complications of diabetes. And then birth control is not a chronic condition, but is commonly used over extended periods of time and also has important public health implications. And we see a big increase. Meanwhile, some of the mental health often is a chronic condition, and medication use is often extended over periods of time, not always, but we see that's kind of at about the average level. And then we see things that are for acute conditions more often, like antibiotics. There is an increase, but it's not as big. So you kind of get this pattern that fits some of the rhetoric. Some of the pre-ACA cheerleading was inaccurate, and I think we already pointed out some of them. But the idea that we would get people into the kinds of treatment they need for chronic conditions, we see that pattern playing out here. In some much more preliminary data that I'm working on with Andrew Lehrer, who's an oncologic surgeon at MD Anderson, he's looking at some registry data of academic medical centers and essentially looking at outcomes for surgical conditions, not always emergencies, but always serious, things that you wouldn't want to just ignore and never get care for. So appendicitis, gallbladder infection, diverticulitis, that's infected outpouching in the intestine, poor blood flow to the limbs that can lead to amputations, aortic aneurysm, a ballooning of the central blood vessel in the body. And what we see here is that there's this divergence that happens around the expansion. Now it's a little unclear why these outcomes seem to be getting worse across the board, but then not so bad in the expansion states. But there does seem to be some kind of divergence going on. And when we looked at are people getting what surgeons, and I'm not a surgeon, but what my surgery colleagues tell me is kind of the ideal or preferred treatment for these conditions, we see this, again, a divergence going on. Now this is, again, much more preliminary, and the changes are concentrated in the Medicaid and uninsured population, but we need to kind of dive a little bit deeper here to know exactly what this means. But I kind of put this out there. First off, this is preliminary, not for citation, these two slides, but it's just, I think, an interesting example of how do you start to look for other aspects of healthcare that are being affected? Most of these studies that are out there already start with surveys, but you really want to get a more textured appearance and understanding what's happening. And you can do that with knowing a drug class that someone's taking for a medication. You can do that by looking at some of these acute conditions and other sorts of studies that I'm sure will follow from many folks. Okay, but enough on how it's impacting patients, because as much as I think that that's a really important issue, if you listen to the debate in state houses and across the country, that's not how most states are deciding whether they want to expand Medicaid, right? They want to talk about how much it's going to cost. And now the ACA was set up to be very generous to the states. The federal government covers newly eligible people at 100% of the traditional match rate, the FMAP. So this means if you enroll 1,000 newly eligible people in your state and you spend $5,000 or $10,000 on each of them, you get all of that money back from the federal government up until 2016. It starts to scale down. It's 95% this year, and after 2020, if there's no change in the law, a big if, you get 90%. That's really generous. Traditionally, the federal government pays about 50 to 75%, by formula up to 83, but in reality, Mississippi, the poorest state in the country, gets about 75% of its Medicaid costs reimbursed. Wealthier states like Massachusetts get 50% of their costs reimbursed. And that's still true for people who are already eligible. There's a typo here, but GOP proposal would change all of this to a per capita allotment, and we'll talk more about that in a couple of slides. But despite, again, a lot of rhetoric on this, where opponents of expansion had said that these expansions will destroy the state budget, and supporters of expansion had said this is going to be, this is great, the states are actually going to save tons of money. There were some nice detailed dives on two or three individual states where people really looked at a specific budget scenario there, but there hadn't been anything kind of systematic where people looked across all states to try to see what the effects were. So this is some work that John Gruber and I again did on the state budget reports that come out from NASBO, the National Association of State Budget Officers. Every year they put out these state expenditure reports, lots of interesting information in it. They tell you not only how much states spend, but what they spend it on. Education, corrections, transportation, public assistance, et cetera. And they also tell you where the money came from. Did it come from state revenues? Did it come from bonds? Did it come from the federal government? So we look at several of these outcomes for the expansion versus non-expansion states. One thing to note, fiscal years run through July in most states, so this is only the first 18 months of Medicaid expansion through mid-2015. We do the log of spending. We have basically each state shows up in our data set, one observation per year. We adjust for unemployment and per capita income. And we also, in addition to just doing this kind of black and white, did you expand or not, we also looked at the gradations, kind of building on the stuff I showed you at the beginning. Some states did really big expansions because they really weren't covering many people. Some states did small expansions, which I think really ought to be the next wave of studies on Medicaid expansion, because it makes it a much stronger finding if you can really tether the result to the states that did big expansions versus the states that did small expansions versus non-expansion. And we also then compared how well, it turns out that each year in these reports, you can look at the prior year budget, and you can also look at what they're predicting for the upcoming year. And we thought this was a good chance to see, like, how good are they at these projections? John and I have both done some of these simulation modeling projections on our own, and both of us, I think, had the assumption that this is really hard to do well, but you'll see the states actually don't do bad. They do a pretty good job at it. Expansion budget effects. So this is just to give you a sense of descriptively what I'm going to show you in the tables. Not surprisingly, when you expand Medicaid, the state spending on Medicaid, the total spending on Medicaid shoots way up. We don't really see much happening on these other big items, and these are the two biggest other outlays for the state, education and transportation. So there doesn't seem like, if you were worried that Medicaid expansion was going to lead to big offsets in school spending, which we hear about as a fear, that doesn't show up here yet. If you thought that maybe you were going to get a huge influx of federal dollars and now you were going to finally fix your ailing roads, there's a little bit of an uptick in transportation, but not dramatic for these expansion states. And that's what we find in the regression results. Overall, if you expand Medicaid through 2015, that we see a 5.8% increase in total spending in the state. All of that's really federal. I mean, it's 12% increase in federal spending and no significant change in spending from state funds. If you look at the category of spending, some of these are fairly noisy and imprecise, but basically the only clear finding is that states that expand Medicaid spend a lot more on Medicaid. We don't see we don't see any evidence of a major offset in other areas. Some of these estimates are kind of marginally significant that some states boosted transportation or other spending. But it turns out that when you then look at big expansions versus small expansions, the only finding that persists is more Medicaid. Yeah?
Patterns for individual states or subsets of states might also be very meaningful here. When you just sort of look at the data, you don't see any of these same patterns that you're talking about people worrying about.
Yeah, so the one that we've kind of looked most closely at is this issue of projections. Because anecdotally, newspapers were filled with accounts of states way overshooting their Medicaid budget. In the aggregate, we don't see that at all. That the projections of what they expected at the outset of the year versus what then happens at the end of the year, they're really close. And you see that none of them are significantly different. So basically total spending, Medicaid spending, state funding versus federal funding, like the projections are pretty good. But that's in the aggregate. And it turns out that by individual states, there are error rates that go from like 26% under where they save money compared to what they expected versus way overshooting on how much they spent. So some states did struggle, but there wasn't kind of a systematic bias that every state was going to way overspend. On average, it actually seemed to cancel out, which is kind of what you'd think if this was just some statistical noise. It's hard to do it precisely, but the states did a pretty good job. Yeah, Colleen?
Yeah, I'm just curious how you determined which categories to compare it to see an offset, because definitely I hear the rhetoric from the states about offsetting education, that they worry
Yeah.
they're going to have to offset education. But in terms of Medicaid maximization, you hear more about mental health, substance
Yeah.
abuse, disability. I mean, and I think that's been happening since the early 2000s, so maybe most of the maximization had already occurred before the time period you're looking at. But how did you
Yeah.
look at that?
No, so these are literally all the categories that are broken down in the NASBO data. So that's our limitation. You're right, and it absolutely could mask some of the important offsets. I mean, one of the main ways that some states have benefited from Medicaid expansion in terms of their financing is by offsetting other healthcare spending, right? So less on uncompensated care or mental health facilities, or offsetting other aspects of Medicaid spending. So for instance, we know that in some states, they've eliminated their programs or scaled down their programs for medical need, where they were typically paying 50% of the cost, because now that population can just sign up for the ACA and get 100% reimbursement. So that's an offset that wouldn't show up here because, or at least we wouldn't separately identify it. It's just part of the overall Medicaid budget. So you're right, and I think for those sorts of offsets, you really want to do the single state studies so you can dive into the specifics. Every state's budget is reported in very different ways.
Yeah.
NASBO is nice because it makes it uniform, but it does it at a somewhat coarse level of aggregation.
Right. I mean, it'd be kind of interesting to simulate, if this same person would have been eligible under the medically needy is now eligible under
Yeah.
the better matching rate. Like you see the offset within the state.
Right.
Actually, this increase would presumably be much lower. Right?
Yeah, well, and that's part of what we're seeing in that first paper on the woodwork effect, is these are people that in the survey were pre-ACA eligible, but some of them are actually qualifying for the 100% match because the state kind of shifted them over.
Yeah.
So yeah. Harold.
I mean, the real budgetary impacts, I think, on city and county governments are just enormous.
Yeah.
And I think that's one of the issues that has really gotten way too little attention because,
Yeah.
like Cook County Health System's running the first surplus. It's basically running for 30 years. And a lot of there's different levels of local government that are affected very differently. And the states are often, a lot of the entities being paid by Medicaid are public sector.
Yeah. There have been some nice studies on the hospital side of this by other folks. Fred Blavin did a paper, and I think Saidi Nikpe did a paper looking at uncompensated care has dropped for hospitals in expansion states. I haven't seen anything on local government and county government, which, you're exactly right. And you think about, there's some overlap there. Some of the biggest safety net hospitals are county-based or locally funded. Okay, so I don't want to oversell the importance of these findings because the way I would say this is the ACA expansion is working as advertised. It was supposed to be a federally subsidized expansion with very little state input, but what this is saying is that some of the concerns that have been raised that states were going to, that there would be a big crowding out of state initiatives, that the projections would be way off, consistently, haven't really been borne out. So essentially, this has been as advertised. The federal government paying a big, paying the lion's share of these costs. How do you reconcile this with what I told you earlier about the woodwork effect? That there's this sizable enrollment among previously eligible. Well, the way I think it makes sense is that the woodwork effect happens everywhere, and we see that in our JHE paper. Even if you didn't expand Medicaid, a whole lot of previously eligible people signed up. So that's a reality, and that does drive up state Medicaid spending, but that happens whether or not you expand Medicaid. All of the other features I talked about, the streamlined application process, the navigators, the knowledge of a mandate, the PR, those were not optional. That happened whether or not you expanded Medicaid under the ACA, and so that seemed to probably drive up total costs across the board, but not specific to whether you expanded.
Ben, do you think in the longer run, when we go down to 90%
Yeah.
match, when we hit a recession, as opposed to a fairly robust expansion at the
Yeah.
time when this rolled out? States
Oh,
will
it
balance
should.
their budgets, and maybe
Yeah.
there will be trade-offs
Absolutely.
funding?
This is a snapshot at 18 months in. And so even if the law stays on the books as is, state spending almost has to go up when states are spending 10% of the costs, right, in the long run. Now, it may not be that full amount if there are offsets of other types that we've discussed, but it should show up at some point. And then, separate from that is the issue of whether the law even does stay as is. And that's kind of what I want to talk about in the last portion, which really gets at, well, what happens if the economy takes a downturn? A lot of that depends on the financing of Medicaid going forward. So I'm going to skip over this because I kind of hit on all of these. I think, for those of you who don't like research and are really bored already, I'm sorry. But hopefully the last 10 minutes will make it at least slightly worth your while that you were here. And I'm going to tell you why I was on the Jerry Springer show. So what's next for Medicaid? There have been a variety of different aspects of Medicaid reform discussed in the repeal of the ACA debate and the American Health Care Act. The most well-formulated and explicit descriptions of the possible proposals really has been from plans over time by Paul Ryan. If you go back to 2011, you can see the budget proposals he outlined. You can see A Better Way was the name of the plan they put out last summer, which really fleshes out his thinking without, it doesn't have legislative language. It's not enough to score it and get an official estimate, but it gives you a sense of what they're trying to do. And what has been fairly consistently on the table the past 2 years or so in these proposals has been the idea that states would be shifted away from a traditional match. Right now, the state gets that match no matter what. If someone's eligible, federal government pays it. Congress doesn't have to vote on whether to allocate the money. It's just automatic. It's an entitlement program. The person's entitled to the coverage if they're eligible, and the state's entitled to get reimbursed for the care. A block grant system would simply replace that with a lump sum to each state. And here's how much you get from the federal government. You decide how you want to use it. There may or may not be a lot of strings attached from Congress. And if you want to spend above and beyond that amount, it's up to you. It's on your state dime. Or something that's a little bit similar but a little different is the idea of a per capita allotment, where you get a fixed amount from the federal government per person enrolled in Medicaid. Again, you spend beyond that, it's up to you. In both cases, the idea, the essential argument is that this would cap the federal commitment to Medicaid. It would make the federal budget more predictable and would save money, and it would give states much more autonomy. So what are the basic economics of these proposals? I guess if you are bored by research and statistics, now you're going to say, but I'm also bored by economics. Then I've got nothing for you. I'm sorry. So if you think about a block grant proposal, it's not that there's anything inherent to it that has particularly positive or particularly negative effects. You have to talk about what kind of block grant it's going to be. So first off, you have two key choices at the outset. What's the lump sum amount? Like, how much do you get? And then what's it going to do over time? So let's talk through those briefly. The proposal that we've seen through the previous year's proposals and then the most recent HCA, the block grant proposal has essentially said we're going to nix the ACA Medicaid expansion money. We're going to just take it away. And so all of that money that right now paid for this 6% increase in total state spending, 12% increase in Medicaid that I showed you is gone. Clearly, if that happens, states are going to struggle right off the bat to maintain the expansion. And essentially, even in states that are fairly high income and committed to coverage expansion, are not going to be able to sustain it. Very unlikely that they could find the funding to make up that shortfall. The per capita allotment takes a slightly more moderate approach. It grandfathers in states that had already expanded as of January of last year. And it does leave some funding in effect, but it doesn't leave it nearly as generous as it is now. They did something kind of interesting in the wording of it in the most recent incarnation, where they said, if you expanded Medicaid for 2016, we won't take your money away. If you've been enrolled in Medicaid, you can keep that coverage, and it'll stay at that 90% indefinitely. And then the small print was, but if you have any gap in coverage of a month or more, you're no longer eligible for that enhanced rate. So, on paper, that kind of sounds like a nod to the moderates in the GOP who said, don't take away Medicaid expansion funding. It's really valuable. Governors in Ohio, governors elsewhere, Arizona, Maine, who expand, or not Maine did not, New Hampshire, places where Republican governors had done expansions and wanted to protect that funding. Well, the problem is, if you've studied the dynamics of Medicaid over time, you know that actually people don't stay enrolled consistently. And in particular, if you look at the non-disabled population that are the focus of the ACA expansion, usually within a year or two of enrollment, only about 25% have kept coverage by 24 months. People have gaps. They don't fill out the paperwork. Their income goes up temporarily. They get an extra couple of shifts in a month and they're too rich for it. They move to a different area and forget to complete the paperwork, and then they reapply. So this really was an underhanded way of eroding the funding for the expansion down to the traditional match rate. Now that's still better than zero. The block grant proposal basically zeroed it out. This takes it to 50 to 75%. But probably even more important than that initial decision, or at least equally important, is how does it change over time? It turns out that this is the sort of in-the-weeds thing that you could never get the public to pay attention to, but makes a huge difference when you project forward and say, well, what will Medicaid look like 5 or 10 years from now? The Ryan plan had originally proposed pegging the allotment that each state got over time to inflation and population growth. That sounds reasonable, right? Except that healthcare always grows faster than that. Healthcare costs never grow at general inflation rates because we have new technology, we have higher prices over time, a whole lot of factors that go into it. But basically, historically, medical costs have always grown faster than general inflation. So if you peg it to that, basically what you do over time is open up a wedge. You might start out close, these show you 3 different scenarios. One is the ACA intact, another is repealing most of the ACA, and then the other is this block grant proposal, not only repealing the ACA, but then shifting to block grants. And what you see is that the initial allotment might be perfectly equivalent under the 3 scenarios, but 10 years out, the lack of accounting for healthcare cost growth leads states to have a huge shortfall. Several $100 billion potentially within a decade that states are out in terms of their support from the federal government. One other thing that gets a little even less attention but is worth keeping in mind is that when you go to a block grant, there's no requirement anymore that states put in any money. So this is a budget constraint, and if you like drawing indifference curves, which I don't, you can draw them on your own time. But essentially the point here is right now, let's say this is your scenario. You're in a state where you chip in $10 billion for a $20 billion Medicaid program per year. Let's say we go to a completely equal funded block grant. You still get your $10 billion, but it turns out that you can now keep that $10 billion and put in nothing of your own. And so just standard economics show that even really liberal states will cut back because they can. They can take, let's say they have a little shortfall and they need to cut a couple $1 million. They can do that without giving up any federal dollars under a block grant system. And so you put these 3 factors together, and essentially Medicaid spending almost certainly will contract substantially, and that's in large part what the policy is intended to do. Now, whether or not its advocates are explicit about that depends on the audience. And sometimes they'll focus on the deficit reduction, but other times they'll say, don't worry, this won't hurt anybody who's already in Medicaid, they can keep their coverage. But basically, with states left on the hook for hundreds of billions of dollars and probably scaling back their own contributions, how do you make up that money? Well, you cover fewer people, you cover less stuff, you take back benefits, you pay doctors, hospitals, and other healthcare providers less, all 3, or you do those big cutbacks in education and big tax increases. Probably some combination of those. And while the per capita allotment's a little better for the reason that you mentioned, which is recessions drive up the enrollment. A block grant takes that into account not at all. The per capita allotment at least gives you a little more when more people sign up, though you still have all these other issues as to how good is the coverage, how much do you pay providers, and that the state has less incentive to spend its own money. So this is kind of the punchline of what I think the proposals we've seen. What would it look like? States would have to make do with much, much less money and would shrink their Medicaid programs. And depending on the state, how much they shrink it and whether they focus on enrollment or benefits or all the above. So finally, is the ACA repeal dead or alive? I don't know. Right now, I think it's in trouble, but not dead. But all of this has really been about whether they could get this bill through the House, and that was never supposed to be the hard part, right? They had a big majority. They had no filibuster to contend with, and they had a pretty partisan representation in the House that was very much against the law. If it were to get through the House in some of these resuscitation efforts, then they would face what was originally the higher hurdle, which is to get to 51 votes in the Senate when they have 52 votes total. And at least a dozen of those senators are from states that have expanded Medicaid, many of whom have come out and said they're worried about any reform effort taking coverage away from people in their state. Governors who have to actually pay the bills and run on whether or not the people in their state have continued to have coverage have largely been critical of the effort to scale back Medicaid dramatically. So this has become a real stumbling block. And it's pointed to something that Harold and I were discussing today, which is despite all of the negative press it gets at times, I think one reading of the past 6 months has been Medicaid probably has saved the Affordable Care Act for the time being. And you see that play out in some various data sources, even in red states. And this is a perspective piece that Arnie Epstein and I published in NEJM, building on that survey in the southern states. We also added Louisiana. And when you ask low-income adults in these states whether they thought the ACA had helped them or hurt them, the majority say it actually had no impact. But of those who said it had an impact, the 3 expansion states here said, yeah, it helped me. And the state that didn't expand didn't have much positive to say about it. And more broadly, when you look at data about the Medicaid program, this is from a large, first-time ever survey that CMS did of 200,000 Medicaid beneficiaries. And people were just asked to rate their overall satisfaction with health care. A third of people said it was 10 out of 10, which was described in the survey as the best health care. And most people are generally pretty satisfied. So, for all the rhetoric about it, people who have the coverage value it, and that's showing up, I think, politically, that it's been a whole lot easier to talk about repealing the law than it has been in practice when they had the votes and had the White House. And so we'll have to see how this continues. There are clearly a lot of interesting issues and challenges in Medicaid going forward. But I think right now on the ropes, but probably likely to emerge largely intact from at least this session of Congress. Then again, I should stop making predictions. All of us should have stopped making predictions last fall. Looking forward to your comments and questions. Thanks for having me.
We have about 2 minutes.
Sorry to not left more time.
I have to be able to tweet that you explained why you were on the Jerry Springer show.
Yes.
And then leave it blank.
Yes. So any other questions before that? Yeah.
You seem to mention quite a bit how Medicaid expansion provides access to care. The American Community Survey has often surveyed the perception of access to care being have you seen a provider? Do you have a provider and such? Are we ready to say that through the expansion of health insurance that having health insurance can be a proxy for having access to care?
It's a good question. So I don't know if this is what you're responding to. One of the arguments we heard the last month or two was after CBO's estimates were that 24 million people would lose coverage on the repeal bill, that Paul Ryan said, we're not interested in coverage. Coverage is a bogus metric. I mean, to some extent, I think that's a reasonable statement. We don't care about coverage for its own sake. But I think the evidence base is strong enough that giving people coverage does improve their access. So if we're talking about access, you have to care about how many people are uninsured. That's not the only aspect of it, and you want to know that we're kind of maximizing the access and getting the access to the right kinds of services and improving efficient care and outcomes. But as a first proxy, any law that takes coverage away from 20 million people is almost certainly going to worsen healthcare access. I think that's a fair statement. But you can worsen access without taking coverage away if you just make it less generous coverage as well. Yeah.
What's your characterization of the arguments around the pros of state flexibility around reform?
Yeah.
Specifically, do you see this pent-up body of innovation that's going to sort of flood us with greater flexibility? Do states have the sort of sophisticated sort of decision-making capability
Yeah.
to take advantage?
I think that state flexibility has a real role to play. I personally think that the Obama administration and the waiver process demonstrate that they were pretty flexible. I mean, states did the private option. States did, Indiana did its health savings account. Michigan did health behavior incentives. There's some lines they weren't willing to cross, and the Trump administration probably will, employment requirements and that sort of thing. I think as long as you actually do an evaluation and make sure you can figure out what's working and what isn't, and you also don't just do what's already been shown to not work, I'm all in favor of it, and I do think there's a real role for this. I don't think we know whether things like the Healthy Indiana approach are helpful or not. I don't think we know we didn't know that the private option maybe it was going to be better for people or not. So I think there is some role for this, but sometimes I agree that state flexibility is just a kind of a euphemism for we want to do less. Let us do less stuff and not spend as much. But all right, Jerry Springer. So Jerry Springer, before his TV show, was the mayor of Cincinnati, where I grew up. And before that, and right after being mayor, before going tabloid, he ran his own community talk show host. He was on local TV and talked about all sorts of issues of importance to people as opposed to did you marry your cousin? And he had me on because I was in 5th grade and I had to talk about the elementary school I went to because I was at a Jewish day school and he wanted to know what that was like. So I talked about learning Hebrew for half of my day, and 3 years later, Jerry Springer was on national TV doing what you know very well. But it's a useful story to be able to tell. So, thanks so much.